I am Councillor Lucy Knight, Chair of this committee, and I just want to welcome everyone this evening. I think it'd be appropriate for us to start with a 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Let's start with the voting of absence. We have had no absence received. Declarations of interest. Do any members have a disposable pecuniary interest in any matters before the committee as well this evening? Minutes of the meeting held on the 29th of November 2022 have been circulated. Are these now agreed and correct? Like to invite, moving to the first item on the agenda, winter crushes, I would like to invite Rob Hodgkiss and Claire Cook to present winter crushes. Thank you so much for coming.
Excellent, thank you. Good evening, everybody. So just looking at the cover sheet, you discussed this at your meeting on the 29th of November, and there was an expectation that winter would be one of the most challenging and difficult for the NHS. Hence the report. I can confidently say it probably has been the most challenging and difficult winter that certainly I and my colleague Claire have experienced in the 20 years that we've worked in our respective organisations. I won't take you through every page of the report, you'll be pleased to know, but I just want to begin by just saying and a shout out to our workforce who have been absolutely exceptional, the tremendous effort that each and every one of them have made going above and beyond in what has been the most challenging of times. I can't thank them enough, and the same would be said for if Claire was speaking as well. If we go to page 13 of the report, you will see in here that the ICS made available in winter £15.5 million. Between Chelsea and Imperial sites, we received £2.4 million. And page 14 and 15 describes those specific actions that we take to use that money. I do think it's important to note that whilst that money was made available, both organisations have spent considerably more on winter. And the combined figure is about £8 million, £4 million a piece across the two organisations. So page 17 and 18 focuses on our ambulance response time, and clearly this has been a huge issue for the NHS at large, and it won't have gone unnoticed the significant press around long ambulance delays and handovers. But I'm pleased to say both Imperial and Chelsea are consistently amongst the best providers in London for ambulance offloads, and you can see the statistics in the paper that you have in front of you. I think that's really important to note as well in the context of both organisations having played significant roles for other partners across the ICS who have at times had some challenging instances with regards to ambulance offloads, most notably our colleagues at Northwick Park and also at Hillingdon, and both Chelsea and Imperial have played their role in helping to support a number of diverts over the winter months, which has just added to the pressure that both of our organisations have had to deal with. But nonetheless, it's been the right thing to do for patients. Page 19 touches on one of the challenges both organisations still have, which is around the patients that reside in a hospital bed that don't meet the criteria to reside. And we're joined this evening by Leslie, the Chief Executive of Chelsea, who is also the National Lead for Hospital Discharge. And both Chelsea and Imperial have got huge plans and working well with system partners to try and reduce those delays as much as possible. But actually the bed occupancy across both sites, both of our organisations, has increased, as you would expect, during what has been the most difficult of winters. And then the only thing I really wanted to pick out on page 20, again, another focus nationally, and made a lot of in the press, is around the 12-hour waits for patients. And you can see both Imperial and Chelsea, despite the pressures, have got relatively good performance with regards to patients waiting 12 hours. And I think one of the things that we're starting to see is some early signs of improvement of those patients from a mental health perspective waiting over 12 hours in our emergency departments. And the new assessment unit at St Charles is certainly helping to support both the Chelsea site, Charing Cross and St Mary's. So they were the key points I wanted to pick out of the report. I'm happy to take, as a short areas, any questions, or have I missed anything that you think? Thank you.
First, thank you for this report, which I still point paints a very positive and optimistic overview picture of what has been an incredibly difficult winter, which is in ways hard to reconcile when you turn the TV on daily and see how well it has been. But yeah, thank you for providing so quickly for us. I think I wanted to start by just talking about collaboration with local authority and understanding from your side what we can maybe be doing to help discharge, and if there's anything that can be improved with us working with you moving forwards.
So I think one of the things that we've certainly noticed across North West London, across the ICS, is there is variance in process and practice, and we have undertaken in recent months a pretty comprehensive peer review process across all of the emergency departments, across the 4 acute providers. We're doing the same now with discharge as well, led by Leslie and Professor Julian Redhead, Imperial, the National Urgent Emergency Care Lead, to really understand where those variances exist in practice with local authorities, with social care, with our system partners, and standardise as much as possible and remove any unwarranted variations. So that would be the first thing I'd say. In terms of where we need to focus, I would suggest, and this is a piece of work being led by the ICS, is particularly around housing and homeless. And this isn't just an issue for this borough, or indeed our 2 trusts. This is a much wider issue, where there are a number of patients residing in hospital that have no alternative place to go. So I think there is a concerted effort required across North West London to really address this problem and move them out of the acute hospital inpatient bed base much quicker. I don't know if you want to add.
I think they are the two things. I think what I would say, the willingness is absolutely there for us, all parties, to get this right, and we're working really closely. We're reviewing our processes all the time to make sure they work as smoothly as they can. But I think because we both work with so many boroughs, it can be difficult for our staff to know exactly what they need to do for all of the different providers and arrangements. But we're working through that to make sure that we improve where we can.
And I think the only other bit I would add is it's I think we've got much more mature this winter has really strengthened those relationships, and I think perhaps we had some of this going on before with finger pointing. I think we recognise where we need to improve our processes, and we're having that dialogue with our system partners, and if we can all improve together, that can only be the right thing to do for patients. So much more dialogue between the chief operating officers and the acutes and the directors of adult social services is something that's high on the agenda, and those relationships are really important to strengthen.
Just quickly, before I get anyone else, just in terms of additional budget moving forwards, I sort of see that in March 2023 is where that stops, and looking forwards to next winter, where we're probably going to be hit with the same flu, COVID waves that we have had this year. Are you planning ahead, and is that budget being ring-fenced for the next year so that we can understand, and will local authority have a sort of better understanding of what they might receive so they can plan forward too.
So I think it's recognised this year, and hindsight's a wonderful thing, isn't it? But I think the planning could have been done much sooner. And I think certainly this year, we're already talking about planning for winter 23-24. To the specific point around funding, there is 47 million that's available across London for additional bedded facilities in the acute providers. So both Imperial and Chelsea have put bids in to try and secure some of that money for the continuation of bedded facilities. There's also been money made available through the National Discharge, 600 million, 300 million, I can never be able to confirm. And I guess one of the things we're doing right here, right now, is demonstrating that actually the money that's coming into the system this year is being spent wisely so that we can secure that money on a recurrent basis for the year ahead and every year thereafter. So I don't know if you want to add anything more to what I've said, but I think we're doing everything we possibly can to ensure 23-24 will be as right-sided and prepared as we possibly can.
And just on the discharge thing, it's interesting, we've discussed discharges for years and years and years, and this is focused on the winter pressure. But I hope that something is going to look in the bigger picture as well at discharge, because it's every time we have a problem, it comes back to partly discharge. So it'll be interesting to see what's new and what's different from the work you're doing that will help that, not just on winter pressure, but more generally as well. Leslie's waving.
Do you want me to help?
Yeah.
Hi everyone, I'm Leslie, I'm the Chief Executive at Chelsea Westminster, and I am the National NHS Discharge Lead. So the government made 500 million, as you know, available to the Better Care Fund this year. The plan is to increase that into next year. One of the things that we're doing right here, right now, so when we talk about what can we do to help, actually what we can do to help is demonstrate really good use of that proportion. I don't know what the proportion of it was for Kenzie actually, but that actually we can demonstrate that we've used that money to move more patients out of hospital. Because what we want our acute unit to do is do the front door at the emergency service front door and do elective recovery. And we want patients in the most therapeutic setting. And a good proportion of patients right here, right now, are not in the most therapeutic setting. If we look in the mirror and really answer that question. So I think and by the way, Bernie and the team here have done a huge amount of good work. But we need to continue with that work. And that allows the arms of government that says not just this coming year and the next year, because that money I think will come. It's that we will be able to demonstrate that we can move more patients out of hospital, transform together health and care, working together can transform the care out of hospital. That's where we need transformation, not in hospital. And that will, I then think, secure the continuation of that funding. So working together, delivering what we've said that we were going to do, being able to demonstrate that in some detail, I think is what we need to do together. And your teams are working on it right here. Right. I can see them sitting behind me.
Okay, would you thank you, Chair. And thank you for this report. I just wanted to know, how does this data compare with statistical and geographical neighbours? And how does it compare with evidence of best practice in health and social care?
So I think in terms of the data that's in here, so the specifics that I've referenced, particularly around ambulance handovers, Chelsea and Imperial are amongst the best in London. And I think London is one of the better regions nationally in terms of the focus on ambulance handovers and category 2 response times, which is a really good place for both Chelsea and Imperial to be. In terms of the long waits in ED, again, Chelsea and Imperial are in a very good place. The area where we don't perhaps perform as well, and there's more work to do, are the discharges from the acute hospital for reasons classed as WS4, which these are patients waiting for social care, and onward movement from the organisation out with the NHS's direct control, and that's what Leslie was referencing in terms of we need to be able to evidence how we're spending that money usefully so that we can make sure that we've got the current funding in the year ahead. In terms of the other statistics, we, both Chelsea and Imperial, in May 2020, undertook a 6-week pilot. We were selected as organisations to pilot a different way of monitoring the 4-hour standard. Nearly 3 years later, that 6-week pilot, both Chelsea and Imperial are being asked to move back to monitoring the 4-hour standard. And certainly for my own organisation, we have been monitoring that regardless of the 6-week pilot that we were in. We are consistently in the top decile of trust nationally for our aim, for our performance. And Imperial haven't been monitoring it in the same way, but they're about to start reporting again. So from the benchmarking data that's available, I think we are pretty clear that we are in a good place. There is still absolutely more to do in terms of improvements. Is that to answer your question?
Yes, slightly, but I will elaborate on it later on in the report. Thank you.
Thank you, Chair. So I have a couple of questions. I know you mentioned a couple of times in the report how the money's being spent, but I just didn't really get a real sense of the extra money.
Okay.
Could you just talk to us a little bit about what the schemes are? What I mean, just things like physical additional beds. I mean, that's
Yeah.
quite difficult to kind of
Okay.
get.
So,
And then another part of the question is also about, and it's touched on in the next report, but GPs. I just wonder how GPs are used to reduce winter pressures, and what more, are they engaged in this? Are they not engaged? Like, what can they do to help? Particularly with obviously the A&E weights.
So Claire and I will answer the first question, maybe Andrew might want to answer the second question. But in terms of the specifics of the funding, so the physical beds, Chelsea and Westminster, we have a ward called Nightingale Ward, which is a 28-bedded ward, which we don't have a budget typically. So it's a kind of spare ward, if you like. So the winter monies that we've received at Chelsea have been to recruit staff to run that ward as an additional bedded facility. So that gave us 28 additional beds. And when I said earlier about we have been spending more as an organisation than we were actually given in terms of the ICS monies, at the peak of the pressures we had 81 additional beds, so over and above the 28 that we had planned for. This was across our 2 sites, both Chelsea and West Middlesex. So for Chelsea, most of our additional spend was on additional bedded facilities, largely at the West Middlesex site, not the Chelsea site, other than the 28 beds. And there were a range of other schemes that we put in, such as increased 7-day working for a range of professionals, not just the ED teams, but actually physiotherapists, pharmacists, to support that 7-day working across the sites. And Claire, I don't know if you want to talk about your specific discharge flow scheme.
Yeah, sure. So at Imperial, we use all of our bedded capacity on a routine basis anyway. So at the beginning of winter, we didn't actually have any physical space to expand into. So at first, our winter schemes focused on some of the things that Rob has touched on around 7-day working, pharmacists, therapists, additional doctors to support discharge at the weekends, those sorts of things. Also on trying to avoid admissions for patients where it was possible and safe to do so through what we call same-day emergency care. So that's a service at the front door of our hospital where we take patients out of A&E, give them the holistic treatment they need and send them home, possibly to come back for some outpatient appointments or follow-up tests and things as they need to. Then actually as we got into the period just after Christmas, when things became incredibly difficult, we realised that we wouldn't be able to make it through the rest of the winter without creating some more additional capacity. So what eventually we did was to relocate some of our sort of outpatient clinic services that were housed in areas that had previously been used for wards, make them good for ward space, and then also open some additional capacity there as well.
And primary care, so primary care is involved with this because it's a kind of system response. So there are various schemes that we've used in the last 2 years, and they're referenced actually in the paper that we're going to come to next. So on page 32 we talk about the extra GP access that we pay for, so there were more appointments available. We also opened up a centre in St Charles to offer more appointments to the community there for 13 weeks of the winter. As well as that, what we do is we ask practices to open up appointments to 111 so that patients who use 111 out at the weekend do have access to a GP appointment if 111 think that's appropriate. We also work with practices to make sure that we help with their resilience, because they get sickness and other things as well, to make sure that they can keep the service open and manage their demands as well.
No question. I think two things that I thought the report lacked was some insight into patient safety and whether there's any sort of learnings you could elaborate on here, and how quickly these problems have picked up and mitigated over the last few months. And then also patient feedback. There was a lot of good examples of plans to address patient experience and flows, but it would be good to have some actual data and sort of feedback from what patients have been saying over this winter and the learnings that you've had from this.
Yeah, sure. So as we're funny enough, as we were talking about the metrics and how well we benchmark, I was just reflecting that we've not put any of the patient safety metrics in here. So it's absolutely right to say we know that patient experience hasn't been what we would want it to be over the winter period, particularly because people are spending such a long time in our emergency departments waiting for their onward care. What we have been really mindful of, though, is making sure that we monitor and manage and maintain patient safety throughout. So with our medical directors and our nursing directors, we have developed a suite of metrics to look at that. It's quite difficult to pull the information sort of out in a way that's easy to measure, but what they have been doing is going through complaints, looking at incident reports, and every time we escalate, we use our escalation policy to its highest level, so we're moving patients perhaps to parts of the hospital we might not routinely use to look after them. We do an assessment to make sure that everybody is safe and that there hasn't been any harm. So at the moment, we're confident that the measures we're taking are safe and aren't creating harm, but we do need to do some more work to be able to sort of produce that information in a way that's easy to share and easy to digest.
And I think just to add to that, I think from an experiential point of view, it's absolutely patient experience and indeed staff experience hasn't been what we would want it to have been.
Yeah.
Absolutely fact. And that happens in a situation where demand exceeds supply, which is what we've seen up and down the country over the winter, and we've done our absolute best to keep services safe as much as we possibly can, and absolutely recognise there has been an impact potentially in the experiential bit for our workforce and indeed for patients.
Thank you, Chair. Thank you for coming this evening. I just wanted to touch on your section 4, where you go into a bit of detail about communications and engagement, particularly on mitigation to sort of alleviate winter pressures and some of the vaccination drives and the COVID boosters. I just wondered, over the last sort of, I'd say 4 or 5 months, particularly on social media, and I'm not saying it's a particularly pleasant thing to happen, but we've had a lot of language about vaccine hesitancy and whether that's played a part in either people not taking up the vaccines as they should. I think actually that's had an impact on flu vaccines as well. So I just wondered if you could talk a bit more about that, as to whether that's been a success in your eyes, and if not, whether you think that has played a part in it not being a success.
Do you want me to do that, June?
So it's a really, really good question. I think so. We have been actually ever since the COVID pandemic, we've worked really closely with our lay forum to make sure that we're able to work with our communities as much as we can to help them and our staff actually understand the information about vaccination so that they can make their own choices. I can talk a bit about in terms of our staff and our numbers and vaccine uptake in that context, but I can't answer particularly in terms of our sort of patient and population cohort, although I know that a huge amount of engagement and work has gone into that with them to make sure that we maximise vaccination as far as we can.
I think it'd be really good to get some numbers on that as to how effective that campaign has actually been, because ultimately that's what we're talking about. Some of these measures are there to try and fix the problems before they become problems. So I think it would be good to get fix on that. And separately, if I may just go back slightly to the point you were just making about how you measure the effectiveness of your service to patients. Strikes me as you're sort of using the metrics about complaints as the key indicator as to whether or not people are satisfied with what they've received. And I think actually if you're waiting for some time, but you've had a good service, you probably won't write a complaint or write in. How do you measure that proportion of people that would fall under the radar who possibly might not be very content with what they've had? How would you go about looking at that? Or is it impossible?
So I should also say, actually, just in terms of measuring safety and measuring patient experience, we measure those things anyway. And so things like the friends and family test, where you ask people, everybody who comes through the service what their experience was and whether or not they would recommend it to their friends and family, is something that we monitor on an ongoing basis. And similarly, there's all sorts of quality metrics we would measure on an ongoing basis. What I was describing was what we were doing over and above that in terms of making sure that the particular pressures that we've experienced over the winter period haven't had a disproportionately negative effect either on experience or patient safety.
Going back to the vaccination, is there any evidence that over the winter there's quite a focus on COVID over the last couple of years on the COVID vaccination? Does that mean that fewer people focused on the flu? It's the same, or is there no evidence that? Because I think there are people who say, I've had my COVID, I'm not going to bother with the flu this year, but there's no.
So the answer to that is actually the flu uptake for vaccine last year during COVID was much higher. So this year has been slightly lower, but there's been some resistance. I think there's some resistance is the wrong word, but I think the community is generally a bit fed up with immunisations anyway. So this year has been a little bit lower for flu, but last year was much higher.
And a little bit lower is not worrying lower and hasn't contributed to winter pressures or has.
So I don't think there's any evidence of that, but I guess it must be a suspicion.
I just wanted to ask about virtual walks and how, if there's any sort of outcome data from this new practice and how sort of monitoring and quality control is done. Well, let's just understand a bit more about them.
So money was made available from the ICB for the rollout of virtual walks. And I think it's fair to say across the country, the uptake into the virtual space has been much slower than what was anticipated. This is a live discussion right here, right now with the ICB, and we're starting to present the data every Friday through our North West London Gold meeting at individual acute trust level across a range of pathways. Clearly the most difficult pathway to do virtual wards is with your frailty pathway, your frailty patients. And we're starting to make some inroads into that right now. I think this is probably something to bring back in 6 months' time, I would say, once we have become much more adept at using the pathways that are available. And certainly Leslie, in her work nationally, is certainly bringing back the learning from different systems up and down the country, where we may need to go and have a look and adopt those pathways and adopt those protocols for a much more rapid rollout. I don't know, Andrew, if you want to say anything more about virtual.
No, just that, like you said, that it's a work in progress, really, isn't it?
And just I'm interested, are there any sort of risks involved in virtual walks and what they would be giving patients into that care? When they might be in hospital.
I think the risk at the moment is more that people will, whilst we're building up the system and gaining trust and confidence in it, that the patients will stay in hospital rather than be discharged into the virtual ward. So I think the cohorts that are leaving it at the moment are the ones where the clinicians feel very safe and confident in terms of the system. And I think where we will get to is that we'll see more and more groups of patients going through that service, but we do need to do a bit more work yet to sort of make sure the pathways work exactly as we want them to, and when we've got sort of feedback and process.
Did you have any?
It's okay. Thank you. Thank you, Chair.
Thank you so much for coming. And I think if possible, Stuart, did you want some? Oh,
Can I touch a bit on the emergency service, you know, the ambulance service? Page 17. So what percentage of the 999 calls were adults and in what age groups and categories? Because as far as I'm aware, I think quite a lot of the calls for 999 are elders. And I would assume that we'll try and find some sort of way to reduce that sort of, call so that we can attend to more emergency cases. Because at times when you go and you see some of our patients, once they've called 999, you realize that just doing the News 52 charge, you realize that some of these cases are really some sort of ailments that can be treated on site. So if it's care homes, is there any way that we can put certain clinicians in care homes to help facilitate this sort of service so that way it will cut, the lifetime for the 999 calls and attend to other more serious cases?
So, really good question, and I can see Leslie behind me itching to answer that. It's
So
a-
you could come and
It's
sell
a
that for me,
particular-
because absolutely, it goes back to, what do we need to transform? We need to transform care for patients who are either being cared for in their own home or in nursing and residential care, where if they get an infection, we go and deliver some IV antibiotics, some embedded fluid, we unblock their catheters, these lot have heard this a lot of times, or catheters, and we provide end-of-life care, because those are the sorts of conditions that mean they're transported. If we did that, when we go back to actually the discharge money and the sustainability of that, what we need to use that money for together, because a lot of this money comes into the Better Care Fund, which is actually used by our social care colleagues, which is how does health and care money and resource work together to do exactly as you said, which means we keep those patients looked after, not being, if you were 88, you don't want to be bounced along in an ambulance to an acute unit, to be frank. You want to be looked after in the bed that you're in. So I'm sorry if there's anybody that's 88, but anyway, besides me. But there is something that so I'm absolutely with you. That's the big piece of work together that we need to do this coming year. That says then those patients are in the most therapeutic setting, and it allows the acute units to look after the other patients that don't get care in a timely enough way, and indeed are waiting for an ambulance, are waiting in our ED departments, are waiting for their hip replacement or whatever. That's the piece of work that we should all be focused on. Thank you.
thank you very much, and thanks so much for coming. I was wondering, in terms of what Stuart asked for, the data on the vaccine, would it be possible to send that to the committee? That'd be really helpful. Moving on to item 5. I would like to invite Andrew Steven, Simon Cook, and Miriam McGraw to present the report on primary care access.
Thanks everyone. No problem. Thanks very much for the opportunity to come and talk to you about GP access, and also for sharing your questions and particular inquiries with us. Hopefully the report will have answered most of those. It's incredibly timely that we are talking about access, because access is, as we come out of COVID, has clearly been a big point of interest for those of us who are working in West London, but also for North West London and nationally as well. So we have been working to try and understand and address issues with access. North West London is also coming up with a standardised GP access initiative. Much of it is based on the work that Joe and Simon and Nick have done here in West London. It's been used as a kind of hallmark of a very good enhanced access service, which is going to be used across North West London. And also nationally, the Interest in Access has generated a national access initiative, which hasn't quite landed yet. So what I'm going to be talking about today is what we've done up until now, but there are two big initiatives that are about to land, the National Access Initiative and the Fuller Stocktake 2. Claire Fuller was a GP, she's now the CEO of Surrey Hills ICB, and she was asked to review GP capacity and access and come up with a review on how to improve GP access. And she came up with three suggestions really. One is that we should understand how we deliver same-day access, that we need to understand how we deliver continuity of care, management of long-term conditions in complex patients, and also health prevention as well, which I think you were referring to with vaccination. Because what she recognised is that GPs up until now have been delivering an emergency care service and an outpatient service with the same staff from the same premises at the same time. And so she wants very much, she suggests that what we do is go back and rethink how we deliver same-day care so that we can retain the capacity to deliver continuity of care from GPs. And I know we're already working with Rachel and other people in your team about how we're doing that. We had a big workshop a week ago on developing integrated neighbourhood teams, which I think referred to some of the things that you were referring to around how do we look after complex and frail people in the community, how do we support discharge going forward. So all of these things are kind of linked up together. So you raised some questions, just hopefully you've read the paper, but again, I guess a slight caveat before we start. There aren't an awful lot of carrots and sticks in the way that we can manage GP access. The big piece of the big carrot, the stick that we have, I guess, is the GP contract, which standardises when GP practices should be open. And it's been the case that GPs practices in West London have been open for the contractual period for the last 5 or 6 years, so we haven't had an issue with that. But we do have lots of variation in access to primary care across West London. Generally, the access, as you'll see from the report, is very good, but there are small areas of variation. So what we have done is work with PCNs and GPs and the Federation to set up extra access, which is universal, so that if you have a particular issue with your practice, you can still get access to primary care, and those are illustrated in the report. And we've also had extra funding through an old contract, PMS contract, with West London has access to some funding which it's using to do the enhanced access for practices in West London too, which is again referenced. So there is variation, but generally we think we come from a good place to get access to GPs. The balance of face-to-face to virtual consultations, which was another question you asked, has clearly been of interest since COVID. It was always the intention before COVID that an increasing range of options would be offered to the community with appointment types, so whether that's face-to-face appointments or virtual appointments, it was always the aim that there would be a bigger mix going forward. It never really landed until COVID happened, and then we had to move to a much smaller number of face-to-face appointments and a much bigger number of virtual appointments. As we come out of COVID, what we're seeing is a rise in the number of face-to-face appointments, but with a much broader range of options for patients to use, whether that's telephone appointments, virtual appointments, online appointments, or face-to-face. So I don't think we'll ever return to the number of face-to-face appointments that we had pre-COVID, but we're certainly seeing a rise in face-to-face appointments. And what we see is that there's not a particular difference in bits of the borough as to how you access appointments, whether that's North Kensington or South. It seems to be a kind of similar match across both. The health inequalities, clearly access to a GP you would think would be a big, would have a big effect on health inequalities, and we certainly have looked at GP access to see if there is a mapping of health inequalities to access. It doesn't seem to be an issue with that, as the one of the ways that we can best measure patient experience of accessing a GP is through the patient satisfaction survey. And you'll see in the appendix here that our PCNs, mostly the ones in the north, have very high levels of patient satisfaction, both with the type of appointments and access to appointments. And in fact, some of the best in North West London, which itself is some of the best in London. So we do seem to have fairly good access to that. We also have prioritised some of the winter access money to North Kensington to make sure that patients who may come from a slightly more deprived part of West London have better access to the extra winter appointments. We've made sure we put hubs in the north and the south, so that there's access to extra appointments at the weekends and the evenings in both areas. And then, of course, what's referenced to in the report are the extra appointments and services that we run post Grenfell, and there's a long list of those which hopefully are hoping to address any extra need that we might have from the North Kensington community. Workload pressures. There is an issue in North West London around the number of GPs and practice nurses, which is something that we have been working on across North West London. West London isn't particularly bad, but we have seen a slight decrease in GPs, and certainly we've got a slightly older GP population than maybe other parts of the country. But it's an issue that we're working with the Federation in West London and with the Training Hub to make sure that we can recruit and retain GPs, so that GPs who come and train here are encouraged to stay here through the SPIN fellowship scheme, and also through support with mentoring and other things too. In the last 2 years, there's been a national initiative to employ additional services to support primary care too, and these are titled ARRS. And there was a fund given to PCNs to employ these extra staff, so whether that's pharmacists or physios or nursing assistants or other types. There's a fund that comes to PCNs. What we have made sure, or supported the PCNs in doing, is making sure they spend all that money that's allocated to them to make sure we've employed these extra staff to support primary care. And that's something that we'll be going forward in supporting the Federation to do as well. And your last question was about Westbourne Grove and hopefully the evidence we put in the appendix is enough to maybe answer your questions there. But we're very happy to take any other questions that you might have.
Thank you very much. Thank you for coming. I'm just going to start with two areas that I want to speak about. Firstly, the effectiveness of digital GP appointments and whether there's any concern of them being as high quality as actually seeing a doctor face to face. And I know very often patients are asked following an appointment to come and visit, but not in all cases. So I've had residents before to speak to me about having to photograph something on their skin or their throat, and whether we need to be worried about misdiagnosing or not catching early signs. Or I mean, I'm not using those are just examples, but how we ensure that things won't be missed through the movement to this digital appointment. And then, so to add on to that, continuity of care, which I know we talk about how we're coming out of the pandemic and things won't return to the normal that we saw before. But I think it's firstly for our most vulnerable and elderly residents who actually, I mean, I've had a number of residents come to me saying they want to see someone consistently who they trust, who knows their medical history, and I think for them it really matters. And I think that's something that is slightly dying, is the GP that you know well and knows you well. And I think, how do we ensure that people can still see the GP that they feel in safe hands with? And I know, and as a result of that, if they do want to see the same GP, it's not going to mean they're waiting for 4 weeks because of the fact that it's shifts and it's not GPs. So that was another concern I had.
Okay, so with the photographing of lesions or diagnosis, certainly that was something that became almost very necessary during COVID to protect both patients and staff. So there was a lot more of that. I get a sense now, and we can begin to infer it from some of the figures, that the need to do that is getting slightly less. And that if patients want to be seen face to face, but they should be able to get a face-to-face appointment if that's what they request, and that would be my expectation, and certainly it's my experience. There will be some situations which might well speed up care by getting a photograph taken, and certainly somebody who has a lesion that they think is changing, there is some good advantage in taking a photograph potentially of that, and then that photograph being shared with a consultant online so that you can get a consultation done much quicker than waiting for an appointment. So there may be some benefits, but it's, we're only just beginning to see the advantages of those types of things, so we're still beginning to work them through. But hopefully, I think what you're inferring is people being hands off, and hopefully that's beginning to change, and if they want to come in, they should be able to come in. With the continuity of care, I think what you illustrated there is something that Claire Fuller picked up around making sure that we don't ask GPs to deal with all the demand that might happen on a single day and offer the continuity of care. Because clearly that creates a pressure, and certainly coming out of COVID, I think what people have been forced to do is deal with the same day access type of patients, which has, I think, had an effect on continuity of care going forward. So I think what we are doing is working with our PCNs and our integrated and neighbourhood teams to work out how we can come up with a service which protects that continuity of care, because we separate off the same day care. We haven't answered that yet. Nowhere's quite answered that, but recognising your concern, I think, is one that we all recognise and we're trying to address. What we are very lucky with in West London is that we have this service called My Care Away, which is a service whereby we can identify our vulnerable and complex patients. We know who they are. They should be invited in for a care planning appointment and have a care plan that's known to all the people that might be offering their care, and would have a lead clinician, usually a GP, who would be leading that care as well. So someone known to them and their family. So that is something that we have in West London that other places don't have. Where that works well, people do feel supported. There may be areas where it doesn't work well, but we're going to hopefully try and make it better.
The only thing I'd add to that is around the additional roles reimbursement scheme that Andrew described before. That's all about putting more people in practices of different roles, and that's to identify people who can be helped by a clinical pharmacist or a social prescriber worker, and all these different skills that we're bringing in practices. And the idea of those is to free up GPs' time so that they can offer continuity of care to those that need them. So it's all adding those, building those PCN teams so that they're bigger and support people and free the GPs up.
Yeah.
Stuart?
Just before we move on the digital access thing, I think everybody agrees that where we can, digital is the way forward. But 5.4, you sort of highlighted some information about the Patches software or system. This was launched in July 2022. I mean, I'm quite tech savvy, and I would always choose a digital tool to improve communication and speed things up. Having said that, I do prefer face-to-face appointments with a doctor, but I think if there was a system that I could use where I could get a repeat prescription, for example, instead of phoning, taking up the GP's hotlines, why would I not do this? However, this was launched July 2022, and I didn't know anything about this. So I think there is a communication issue somewhere, because you could probably find that a lot of people are taken out of the system entirely if only communication was improved. And I had no idea this even existed. And as a patient, in what I consider to be one of the best GPs downstairs here, I've never had a problem, but I would have assumed that I would have been contacted about this.
Yeah.
So those you're right with that one as well, particularly because obviously enhanced access is a key thing here. But this was an education to me, this paper, and there were so many services in there I knew nothing about. Just how it's publicised. I can show you how to get a repeat prescription later. But how is it publicised? How does the person? Are we reliant on our doctor's receptionist telling us, or do
We don't have a letter.
Yeah, interesting.
Yeah, so we have been bombarding patients with information during COVID. So we've had lots of messages back saying, please stop, particularly texting patients with things. Patches is something that should be advertised on patient websites, on practice websites. So when you contact your GP or you look online to your GP, then the patches option or the online consultation option should be something that is opened up to you if you go online. Receptionists will mention it. A lot of practices are still working out how to put it into the way that their day-to-day working as well. So some practices are still working it through. What we are contemplating doing, and what our neighbours in West London have done, is setting up an e-hub, which is a hub that takes all the online consultations in as a way of managing demand. So they've got a team that are managing the online consultations all the time. It may well be that's something that we decide to take up here in West London as well to improve access to. I take your point though about communications, we can certainly take that to.
Sorry, no, sorry. I was just going to say just one very quick point, that in terms of disparity in experience in different GPs, I think others will probably touch on that shortly, but whether that issue that you just highlighted about the digital access and it being different, whether that feeds into a wider problem of this disparity we see. And I'll shut up there because I'll...
So it's certainly something we measure. We measure uptake of patches and how it's being utilised. So it's something that we're monitoring, and we ask questions about it with PCNCDs and practices themselves. West London and my practice particularly has a very low uptake in patches so far. So it is something that we're working on, something we're monitoring.
Portia.
Thank you, Chair. I think for this new care model from the ICB, I think I've got 3 questions. How comprehensive is the plan? Does it address the presenting concerns? And how have patients and carers been involved in co-producing the plan?
So this is the fuller care model.
Mm-hmm.
Yeah. So as I say, this is a piece of work that we've just started. So we had a workshop before Christmas. Claire's paper landed towards the end of the summer. So we've had a North West London workshop, and we've had 2 workshops since then. All of the workshops that we've had have included patient groups. And the last workshop that we had last Wednesday was very well represented by patient groups, Health Watch, and individual patient groups and resident groups as well. So it should work. The actual model itself hasn't been defined because it's still a work in process. We're still doing that co-design, but we'll certainly very happy to come back to you once it has landed.
Yeah.
So just in advance of that workshop, we also did some in-depth patient interviews. So we identified different patients that had experience from different parts of the life cycles. So some who managed children or look after children, and some more at the older end of the spectrum, to have sort of people went out to their homes to interview them, to give them the sort of time and the space to capture their information. And then we, at the workshop, used some of these examples to sort of practically talk through how their care might be managed in the sort of new model in the way going forwards. So we're definitely making sure that we involve patients right at the beginning.
And carers.
Yeah, okay.
Because in order to understand your need, you have to speak with the service providers.
Yeah.
Those who are providing the service.
And certainly that's been our experience in the past. My Care My Way was a co-designed service with patients and carers as well as physicians as well. So it's something maybe we haven't done as much as we could have done, but it's something that we strive to do, and so we have every intention of doing it with the fuller work.
Thank you.
Thank you. I also find this an education, so it's really useful. I wanted to talk a bit about the North Kensington recovery and the enhanced health checks. Well, I guess a couple of questions here. Do you think 1,175 checks is a lot in a year? And how are you promoting this? Because I think this is really important, and actually many people in North Kensington have asked for this and want this. But there can be some residents that are quite hard to get to and quite hard to promote this kind of service to. So how are you doing that? Yeah, I mean, tell me if you think 1,175 is a lot in a year.
So I don't know the answer to that. Certainly we monitor monthly the number of appointments that are taken up, and what we've been able to see that there have been different numbers that have happened at different times. depending a lot on things that might be happening to the community, national press stories and things as well. So, and we work with Grenfell United and other resident groups to make sure that we get the message out around the availability of these services. We've used social media, we've used faith groups, we've used newsletters, we've used pamphlets, we've done what, and we've also gone to the community and say, what is the best way to communicate with you? And that's something that we do constantly. The actual number, I think, we also work with GPs to incentivise this work with GPs as well. So there is an extra budget that we use, and we work with CNWL as well to deliver this service, so that we've got people who are available to do the service. And initially, patients had to go through their GP. Now they can just self-refer for these checks as well. So we've tried to make them as accessible as possible. Just got to pass the note. Does seem to be a levelling off of need, apart from recently when we had the Mirror story around our first attenders. So there seems to be a levelling off of need, despite, but we do monitor that, and we do monitor who is accessing the service too, to make sure that we're getting the message across.
So I was only going to add that the period in question is a period when there was an awful lot of COVID in terms of about 1175.
Yeah.
So patients weren't generally coming out to go and see their GP during that time if they could have possibly avoided it.
But we had other means of keeping that open. So a lot of the Grenfell services were deemed as essential services. So staff weren't moved to other COVID services. All of the Grenfell enhanced access services were maintained even during the COVID period.
I mean, I don't know, but it doesn't feel like a very high number
No.
to me.
No. But we do. I mean, there are colleagues who come along to the North Kensington boards, that health boards we have, so they would have access to the numbers, and we have monthly reports on access. So very happy to share that with you.
Just thank you. Just looking at future and staffing and sort of paragraph 6 and particularly on page 37. Clearly we're moving to these multidisciplinary teams, bigger practices, moving away from one GP practices. They're becoming more complex organisations, bigger organisations requiring much better levels of leadership and management. I guess I was slightly interested to see we also know that only about half of nearly qualified GPs entering the profession do not wish to become partners. What's the future of that? The future of people running these quite complex practices?
Yeah. So the answer is we don't know. There is a general suspicion that primary care may be making a decision to move away from small corner shop primary care services to something a little bit bigger, and there are lots of advantages of that, but we're aware there are some things like continuity care that we may lose along the way, which we'll have to safeguard against. There are funds along supporting management development of these services. So we've got funding that's coming into PCNs that's helping to make sure that they can manage and plan. The quite significant funds that are coming into PCNs around delivering services, and a lot of the services that we were hearing about that need to help us support discharge and need to keep people at home are going to be delivered through PCNs and integrated neighbourhood teams going forward. So there is a step up in the skills and the type of people that run those organisations. We're very lucky in West London. We've got the Federation, which are all the PCNs working together, and they themselves have paid for chief exec and financial officers and others to help them manage the funds that they get, to make sure that they get access to all the funding that they can and can provide the services, and they performance manage what they deliver too.
Is there a danger that our most senior and perhaps experienced doctors cease doctoring and become accountants? Or
so no,
like many professions.
I think that's probably a different skill set. So I think the days of the enthusiastic amateur manager we're probably leaving behind. So if you're a physician or a doctor, then that's what you'd be expected to do, rather than manage a practice as a business, which is what we have had to do up until now.
Yes, I just wanted to add.
Yeah, I mean, just to give a flavour, when I started working in this patch, I think it was 55 GP practices, and now we're down to 40 odd. And that is going back about 10 years. So, very significant reduction in the overall number of practices. And I think that will continue, to reduce the number. But as far as what there's been a lot of talk today already about variation across practices. These bigger groupings are fantastic in working together, supporting each other. So you've still got individual practices. You're still able to maintain that, sense of almost intimacy that patients look for. But at the same time, they work very closely together. They support each other. They benchmark the services that they offer against each other. So it is all the while reducing that variation, and that does obviously seems to be a big theme, understandably, that people are interested in today. So I just would want to emphasise that I really see it as a very positive direction of travel that we're on here, where practices are working more closely together, supporting each other. With the sort of workforce challenges that we've heard about as well, it's even more important to see that, because individual practices working with list sizes of 4,000 or 5,000, you might have 1 or 2 GPs. There are a lot of GPs part-time nowadays. It's a very flexible role that people want to have. So by working in bigger groupings, you're able to offer services over longer periods of time. Patients can access evening appointments, all that kind of thing. So I understand that there is an anxiety up and down the country about the way that GP practice may be heading primary care, but I think that there's an awful lot of positives that we need to focus on as well.
Thank you.
Thank you, Chair. I do engage in my local community quite a lot, and I've just got a question to ask you on Appendix 3, page 50 here. How and what provisions would you put aside to help those who do not speak English very well?
For
And
the
they're
patient
in-
survey.
Yes, for the national survey, and also to have a more pleasurable care package. I mean, you need to gain trust from your, clients or your patients, and if you cannot communicate with them effectively, there's no point in providing them with service. And I'd just like to know what provisions would you have in place for those? And are you aware of the amount of nationalities in the north and the south of the borough?
Yeah.
And what provisions are you going to put in place for them?
Yeah, so that's something that we are aware of, and it's one of my roles as medical borough director, borough medical director, and it's also the role of the clinical directors of each of the PCNs to understand the populations that they look after, and things like cultural competency and other things are very important for them. The survey does come out in a number of languages. I can't tell you exactly how many it does come out, but hopefully patients will have access to a survey that they can interact with and understand and feedback on. So hopefully language won't be a problem. Well, I don't anticipate language will be a problem. What might be a problem is explaining to them the value of giving the feedback, and that may be something that we need to work on going forward. Practices that we have improved the language and translator services that primary care has access to as well. So increasingly there will be no need to use relatives as a form of translation, either on the phone, online, or in face-to-face consultation. That will have a translator to use that going forward too. One of the benefits of Patches is that it is a multilingual service, so that people can use it and it translates at the same time.
I'm going to come to you for the last question later, but just going to ask, in terms of Appendix 2 and the data from the RBQC surgeries, how often are these practices monitored, and also when they're not performing, what assistance they're given? So it's particularly with what Stuart's saying, as we sort of compare different surgeries. Are surgeries being guided in terms of digital access? Because I don't think necessarily those standards are the same. I mean, I've been probably the last 3 years, I've had 3 different surgeries, and they all have very different digital access or receptions. There's just how are surgeries helped and guided if they are performing badly, and how can you guys jump on?
So certainly if if anything happens with their contract and they fall below their contractual baseline, then North West London, that's monitored monthly, and North West London will jump on that as far as their contract goes. We work with PCN CDs, understanding variability and talking to the CDs and practices about why there might be variation in their numbers. Most of the practices that we've got working in West London are green or amber here, and they tend to be moving up. This comes out of the incentive scheme that we set up for practices. So it's not something that we can punish practices for not doing, but certainly there is a financial incentive for engaging it. And we will often talk to them about what they're missing out on if they're not delivering services. And certainly it informs us around a conversation that we might have with the PCN if we begin to see any issues. But what we see here, and you have to trust me because we don't have practice names here, is that most of the green practices are spread across West London. There isn't a pocket of bad practices here and a pocket there. They're kind of spread out. And we do seem to have very good access around the PCNs that we're working in. The variability around access is something that we maybe have to carry on having that conversation with primary care about how it's done. But there's been an explosion in this online facility in primary care since COVID. So I think it's still something that's kind of landing and settling.
Linda?
Sorry, I was trying to get into.
No, you don't.
Before. It's a very interesting report, but one of the things that I'm concerned about is the amount of people that perhaps due to COVID did not see a doctor and therefore are now presenting in quite far advanced or whatever. I don't see how that has been factored in. Could you possibly answer that?
Yeah, so we do recognise that there was perhaps a lot of patients that didn't get their normal care during COVID and made a choice not to make themselves.
No, I'm talking about people who are now presenting with cancers and
So there's lots of things. So cancer, certainly making sure that we understand where we might have missed cancers in the past because people didn't present. So we're encouraging primary care to recognise early signs of cancer or potential signs of cancer. We're monitoring the number of 2-week waiting referrals, which are the potential possible cancer diagnoses that are being referred into systems. So we're monitoring that with the acute trust so that we know the numbers that are going in and how many of those patients that we refer in are being confirmed or reassured that they either have cancer or they don't have cancer. So that is something that we work with.
And do we know how many people potentially? I mean, it's just anecdotally that I know that a number of people have been identified at stage 4 that might have actually been identified earlier if they'd been able to have access to the doctor.
Yeah. So we're still working on that. So there's a group that the ICB runs, which is a clinical safety group, which looks at waiting times and the impact of a diagnosis, and it monitors whether a delay in access to a service or referral into a service has made a difference to the outcome. So that is being monitored, and that's led by a colleague, Leslie Roger. Yeah, Roger. So that works regularly, and that works with all the primary care. I work with Jim, and we work to see if referrals in delayed referrals have made a difference to outcome. I think we're still working through the numbers on that to see if it has made a difference.
It's just I didn't see it.
Yeah. So partly because it's slightly different access, but it's a really good question. The other thing is that we know there are cardiovascular diseases like hypertension and other things that maybe haven't been monitored as closely because of COVID, which will have an impact on things like heart attacks and strokes moving forward. So we are using the clinical effectiveness group to look at where we might have missed diagnoses in particular populations. And with health inequalities, it's forcing us to go into groups and make that, so we're not waiting for people to come to GPs, we're actually going out to certain groups and saying, we don't have enough people being treated for blood pressure or other things in this group of diabetes, therefore we need to go and see where you are.
Stuart.
Sorry, can I just ask one very quick thing? It's not strictly related to access, but I think these figures that you've got on this pending are actually very positive in terms of the number of days waiting for everyone. 1, 2, 3, 4, 5, and the highest one is 9, I can see on that, which is actually really good. So that's fantastic. Particularly when you get into a GP, there are certain things the GP can fix, give you prescriptions for things. There are other things clearly that need referrals. When I last saw a GP, he was very honest with me and said that an MRI would take months. If there would have been a suspicion of anything more serious, you would go down a cancer pathway, you'd be treated very quickly. But for that gap in the middle, I mean, how do you, is there any discussions you have with your colleagues to try and move that process along? Because months is a long time to wait for an MRI. When you
It is.
It is sort of slightly following up on as well.
Well, it is, and it's one of the so access to diagnostics and access to specialist opinions is one of the things that I think did suffer because of the concentration on managing COVID during the pandemic, and we've got this big backlog that we're getting through. But the backlog is coming down, and the work that Roger's doing, and the Acute Trust is bringing that down in something that we're monitoring. We've set ourselves targets to achieve that going forward. We are working with across North West London about how we bring some of those services out of trusts like the hospitals and bring them into the community, so they're slightly easier to access, and the waiting line for them has become less. So some diagnostics, not an MRI quite yet, so things like ultrasound and ECGs and spirometry and other things are coming into the community. What we're hoping to do with the work with the integrated network teams is include specialist opinion around how you manage patients in the community. So rather than waiting maybe for an outpatient appointment that says you may need an MRI or you may not, how we bring that expertise out in primary care so that we can speed up the access to that expertise. That hasn't landed yet, and that's a piece of work that we're doing around the model of care, is about how we bring that expertise into the community. Does that answer your question?
Yeah, I think it does. I have a slight worry that isn't moving as fast as you certainly suggest it is now. And this is only from anecdotal experience on the ground. But also that, I think for me, it was sort of suggested that the only way to get your MRI is to pay to go privately, basically. And that's fine for someone who can afford it. But
So I think that is a conversation a lot of GPs have, because it does answer a question. But I think what we're doing in the long term is making sure that patients get the best advice at the very beginning, so that any unnecessary tests aren't done, they don't clog up the system, that we get the right people in to get tests. In the past, GPs could refer a lot of people into MRIs and got them done, but it didn't mean the system was overloaded with requests for MRIs. Now we have a system where people go through, if it's a musculoskeletal problem, they go through a team, they're assessed by professionals and consultants first, who say yes or no, an MRI is useful or it's not, so that we can reduce the number and improve the access.
Sorry, I won't take up any more time. Just one point on that, where the GP doesn't really know what the problem is, and has to refer it to a team, that just adds another layer of.
So we've addressed that too. So what we've set up, and this was happening before COVID, is there's an advice and guidance. So if you have a question and you're not quite sure what the right thing to do is, there's a service where you can send in a question to a team and say, what is the right thing to do? Is this something I should do a test for, or do you want to see them? And we get a reply, and that hopefully avoids a referral, or it speeds up a referral, depending on what is the right thing to do. Hopefully we're beginning to do the right things.
Thank you. I was just going to ask one last question, just on Westbourne Grove, which obviously has had a lot of noise around it in recent months, but just an understanding of what other practices might be a similar risk to this, and what the kind of key learnings from what's happened there.
Yeah. So I think, we're very sad to lose Pearl, but I guess one of the problems when you are a single-handed practice is that everything's very vulnerable depending on the health of that individual and the choices that they make about their careers. So I think the fact that practices are moving together to work in PCNs
is something hopefully that will mitigate some of that risk. But we do have our contingency plans where practices support each other should individuals get sick, or a number of people get sick. So there's a kind of buddying service where they support each other going forwards. And what we do know is that there seems to be enough capacity out there of GPs to serve the population that we have here in West London. So it's really unfortunate what happened with Westbourne Grove. But there were issues with Westbourne Grove that we were probably going to have to address, or we were in the process of addressing anyway around the premises.
Yeah.
So I know that they were working to maybe find another place to work from anyway.
Thank you. Thank you very much for coming. Now moving to item 6, data. I would like to invite Councillor Sarah Annenberg and present the data centre opportunity report.
Well, I'm going to take it, you've all read it.
Paragraph 2, line 3. Yes.
Okay, as Councillor Albert said, hopefully we'll have a chance to look at the report. Usually when we're thinking about day centres, the day opportunities, day services, we want to think about those for older people, but we try to reflect the breadth of the opportunities that are commissioned and available for residents in Kensington, children who must support both, including people with mental health needs, residents with learning disabilities and physical disabilities and sensory impairments. It's important to do that because that does reflect the range of offer, but also it reflects the protected and ongoing investment in those services that Kensington and Chelsea has maintained. When in some other parts of London, the investment in those services has fallen away over recent years. So there's a very strong picture of those services and the funding for those services in the borough, which we should be really proud of. The report also indicates that whilst these are commission services, and some of those are described as primary, secondary, and tertiary services, so those that people are referred into, whether the tertiary ones, whether they have assessment through social care, and that becomes part of their support package. There's also very good use and connection from these services to the life of the borough, to the universal services that might be made available by the council or that exist as part of the cultural life of the borough, that these services make a lot of use of and help support people to remain independent in the community if they also have social care needs. With one of our in-house services, for example, the Learning Disability Resource Centre at St Mark's Road, most of the staff and the customers there spend most of the day outside of that building, visiting places across the valley, parks, leisure centres, exhibitions, whatever it might be. So there's a mix of these services in terms of how they make use of what's available locally. And just one final point, I think, by way of introduction is about the legislative basis for these services. So often we might talk about a distinction between statutory services and non-statutory services in other social care. And day opportunities or day services sit on a bit of a blurry line there, in my view, because what we cite in the report, various bits of legislation that give us responsibilities and duties around continuing to invest in preventative services, keeping people well in their own home. The description of those responsibilities in the legislation isn't probably quite as hard as it is for some other bits about responsibilities like assessments being undertaken, reviews being undertaken, access to care homes, access to home care, etc. And yet there is a basis for this in legislation, and working with colleagues in the NHS who have just been talking to that investment in keeping people well at home and part of the community is a significant contribution to a well-operating health and social care system.
I think one thing I'd like to add is it's a shame because of COVID, we couldn't visit some, I know you've only just joined, but I think it's really important that everybody goes out and visits some of these day centres because you really get to understand, what they provide. And one particular one is the St Mark's Road, which Anne and I spent a bit of time at over the years, which is not fit for purpose. And that's why, it's so important that Maxilla is now going to go ahead, which has been co-designed with the community. And it's going to be a fantastic social care and community hub. So once you can, maybe we can plan some visits. I think it's really important that everybody goes out and sees what's on offer.
Thank you. Before COVID, the disability place in St. Mark's, it was running very well. I don't know what happened after Grenfell. So I would like to know what happened, why the services were run down, why we have to move to Maxilla. Why couldn't there be a continuity of care on that same level until we move to St. Mark's?
They're still using it.
Yeah, they are, but why are the service levels run down? It's not fit for purpose.
The building is not particularly, it has stairs to go down to the basement area, well, it's a half basement, so it's not a particularly good place for people with disabilities. So that's why we want to move it, because then we can have more people going to a much better designed building. The access is the issue there. It's old, it's tired, and the access. So it hasn't been run down, it's just...
But what are we going to do about the air pollution on the Maxilla?
The air pollution?
Yeah.
That will be, that has been raised by a couple of the service users, and so I know some people in the area in terms of it being under the Westway, so the fallout pollution vehicles over and above it. And that had been the case in the past. There was a nursery on the site of the issue. And so with both Maxilla City, the community interest company, us as the Council of Social Care, and members of the community, the service users have been helping in the design. We've been giving very strong design steer to the partners that we're working with on the development about how those sorts of environmental protections can be built into it. So there will of course be times that people are making use of the space outside, as they do on the roof of St. Mark's at the moment, also going out about the community, but it will be a formal part of the requirement of design of the building, the environmental protections building.
I think that needs to be in place because it's under the Westway, and if we're going to move to a bigger location with more resources, I think those sort of things need to be put in place in order to think about how we're going to address, because a lot of people will complain about it. There's no point spending so much money knowing that we're going to go into problems.
But as Gareth said earlier, most of the time they're actually not in the centre. They get on the buses, they go swimming, they go to the Albert Hall. We've now got we're about to get a changing places toilet in the park. So that allows people to go out more and more, and it's really important that they go and use our parks in particular, I think. So they do spend a little bit of time there, but it's in relative terms, it's actually very small.
Thank you, Chair. So I've got a few questions. As you know, this is my, favourite group of organisations, and I think the work they do is incredible, and I think we should be doing everything that we can to support them. So can you talk to us a little bit about when these services are going to be recommissioned? Because what I kind of feel is that we need more and more of this. And the need is only going to increase, and I worry about the budget, and is the budget going to, decrease, and how's that going to impact, some of these organisations? And I do sometimes feel a bit concerned that, it's hard work, I think, what these people do across all of these categories, and I really feel like we at the council need to support them, and they've got to feel like they're valued and, a good partner with us, and that we will do anything that we can. I'm not sure they always feel like that. Yes, sometimes, but not always. But yeah, this budget piece does concern me. And actually, I'm also wanting to ask what's happening with Pepperpot.
Yeah. So we are in the process of. I'm just making notes. Don't forget your question. No, thank you for those. We've been in a process for, I'd say, probably the last 4 to 5 months with the providers of older people's day services in particular, to think about the way that they're delivered currently, check to see if that is still a fit for purpose model, and to talk to them collectively about anything that might need to change. That discussion has been had partly with a view to thinking about, are we spending the right money in the right places, but also about whether those with the most need, who could benefit most from those services, are accessing the services in the way that they're designed currently. And the providers have all participated wholeheartedly in that discussion. What I'm pleased to say at the moment is that we're not really having a discussion now about any changes to the funding. That may well come in future years, but for the short to medium term, the investment that we're making in day services is set to continue. That's a challenge for us in social care and public health, because public health funds for these services too. Because, as you will know, the medium-term financial position is challenging, and as a department, we've got an ambition to look for value for money as well. But this principle around investing in prevention and that paying off is right. So we've looked to protect these as much as possible. So that's not on the table at the moment. That doesn't mean we shouldn't look at how the services could be done differently, and we could reach those who might make the most of them better than we do at the moment. So that design work will continue with those providers, but we're not at present asking them to look for any savings. In terms of the recommissioning, we will continue with the contractual arrangements that we have with them at the moment, but that redesign and transformation work will go on. So if there comes a point where we think we might need to go out to tender or to some other form of procurement or sourcing of the sector, then that will happen at an appropriate point. But we're not putting ourselves in a position where we need to rush to that, because we've secured the arrangement for the short to medium term. In the mix of that is Pepper Pot, and Pepper Pot's particularly for a number of reasons. It is one of those building space services, so the ability of the council as the landlord of the service to let a lease for the use of the building is contingent on us having a commissioning arrangement in place with the service being provided there. So we're now able to say to our colleagues in corporate property, our intention is to continue commissioning Pepper Pot, and so they will be able to put a lease arrangement in place with them. But now the trustees of Pepper Pot might want to talk to the council about how long that can be. And so from our perspective, in terms of the existing commissioning arrangement, that the term over which they might want the lease, the term at which we can afford to commission in the way that we are at the moment, might not completely align. So there may be some debate there, but there is security in the short to medium term, next couple of years around that. The other thing that we've been talking to Howard and Staff at Pepper Pot is about is simplifying some of the arrangements there. And this is done in the kind of what we hope is the best interest of the organisation and its customers, because at present Pepper Pot is a mixture of a drop-in service. Anyone can come along. People come from other boroughs to come and use it, and it be kind of funded by the council, and that's great. It makes really good use of the space, has a good offer. But it's also a service into which people are referred. So if somebody comes through an adult social care room, has an assessment or a review by the social worker to benefit from day services and refers them into Pepper Pot, we've got a little over a dozen, somewhere between 12 and 15 service users who are accessing Pepper Pot in that way at the moment. One of the problematic things about that is that if you walk into the building, you don't notice the difference. If somebody's been referred in by social care, or if somebody is a drop-in customer, it's a kind of a great community of day centres. You don't really know it. But those people who are referred in because they're coming from another social care route, technically are liable to be assessed for their ability to pay for that service, in the same way that anybody would for any access to the social care service. So they could be at a slight disadvantage being asked to pay for something that somebody just accessing it as a drop-in would. So what we're proposing in some of this discussion about redesign is, what if we continue the funding the way it is and drop the referral in, so people will still have access to transport to get to the centre, and people will still be able to use it in exactly the same way. But if anybody at the moment is in a position of
being charged because of their assessment or of future use that come through that route line, then we would just negate the need for that by making the whole thing a community shopping centre. Now, they might have some thoughts or concerns, and they do, so we had a chat with Howard and the trustees last week about that, and they'd like us to come and talk to them and some members, explain it a bit more, so happy to do it. But I'm confident that that's a positive offer.
It's really good news, thank you.
Stuart.
One question about, I think you might have touched on it in your reply there, so forgive me if I'm asking you to repeat yourself, but the value for money element here is 3.7 million or something like that is a great 3.7 million spend on commission services. And I just wondered what your assessment or how you assess value for money on that. I mean, in the grand scheme of things, it's not an awful lot of money, but it's still 3.7 million pounds, and how do you make sure that money's being spent wisely?
So we do it in a kind of a usual commission way. What we don't do, I think thinking about is a really good thing for us to think about when answer a question, is a wider value for money or cost avoidance. So we consider value through the indicators and performance of the contractors we set out in specifications. So we quarterly meetings with each of these providers, we look at the returns that they tell us about delivery and assess whether that's meeting the targets and expectations that we have as a public funder. So that would be in terms of the number of people who are using the services, all the feedback that they're giving, the number of times that people are avoiding having to use secondary or tertiary services, going to hospital, that can be reported through those indicators. And often there's what's called a kind of well-being star approach, where a number of measures that people would self-report in terms of their own health and well-being come back to us as part of that contractual arrangement. So those are the sort of things that we would look at. So I should also say the demographic factors, so age, spread around the borough, people's ethnicity, which we can learn to kind of map onto our known picture of need, the health picture. What we don't do in a kind of systematic way across each of these services is kind of plot and track the number of people that are using them, their kind of likely conditions, and what the benefit of those services is doing in terms of somebody not perhaps needing 30 hours of home care if they're using the services, and look at the cost between them. We do that for some things where we're making a business case to invest in something. So the investment in Lots Road as an elderly care facility, we can draw a picture that says doing that is not only better outcomes for people, but it's providing better value for money than somebody having a period of time in their own home care and a period of time for care. But we don't at present do that in that sort of systematic way that these commission does. So,
I would like to know why there are no day centres in the centre of the borough, where we have 8 residential homes and a lot of isolated people. They cannot get to the north of the borough, where most of the services are provided.
We thank you for the question. It's not deliberate. The centres that are used have been in place for a number of years. Some of them are newer, like Newich, New Horizons and the Reed Centre. But the spread could always be better, but we do also fund a range of services that are both peripatetic and outreach based. So that includes the stuff is in that area, but also the transport, the chauffeur services that are there from where you the friendly services that Octavia provides. There are for people who aren't able to travel to a particular building or access the transport that can take them to a particular building. We also in recognising that, there will be all of the patches across the borough. There are other as well.
I'm just concerned about the socialisation, and there's some, for example, in Common House, which is quite proactive. But you get Bullburn Court, or you get other residential homes where there is very little action. within the residential sheltered accommodation. And so therefore, people do become isolated and therefore don't identify problems until quite late. But it is this kind of focus when you say Age UK, for example, sponsor them. But when they put on events in Earls Court, majority of people that have turned up are come from Kensington and not from Earls Court. So there may be funding organisations, but it's a question of whether they're actually targeting people from the centre. We know we've got a lot of older people who live by themselves, as well as people who are in residential homes. So I'm just wondering whether we're actually targeting the right people and actually getting these organisations that we fund to target people.
Maybe we should talk to Zara, because they certainly go into supported accommodation and sheltered accommodation and do armchair aerobics.
But it's actually trying to say, for example, use Mary Smith Court, you could use that, and you could use that as a focus for some things. But actually getting things to get people where they walk to the place or get activity within the place to promote socialisation and reduce isolation.
Any other questions? Gary?
That was a comment that's sort of in the question, going back to the bit about cost avoidance and how we measure that. And I think that's something as a borough we haven't done very well over a long time. Because what this report shows, isn't it, again, which we know, but it highlights again the reliance of the third sector in supplying so many of these things. The one centre I know, the Smart Centre behind Hospital, if you look at the ripple effect of that, from the services they supply in the core to what it then does out in the community, it's immense. And therefore, as a borough, I think we support well, but we need to continue to support our third sector to make sure it's vibrant, because the avoidance cost is quite extensive. And I don't know how we do that piece of work, but it would be an interesting piece of work to do.
I think something that if we're to embark on it, doing it with the sector and with those providers will be key, because an organisation like OpenAge, or UK big enough to become like that, they do a lot of that work themselves as part of their wider bids for funding beyond what local authorities have done. One of the things they often say to us is us having been able to retain investment in those services is a good bit of leverage for them to attract funding from elsewhere. So if they can demonstrate that the local authority has paid in the organisation to keep funding it, it brings additional money in. So yeah, do that.
Thank you.
I think that's the questions. Thank you guys so much.
Well, I just encourage everybody to go on some visits.
Yes, I mean, that was what Associate James was
Actually, Smart would be a good one.
organised.
So, Chair, we can take that away as an action.
Yeah.
And the department and come back to the moment about possible signs,
Yeah.
times, maybe try to do one before the end of the year.
That would be great.
Thank you.
Item 7, select programme reports. I'd like to invite James David Diamond to present the select committee programme.
Thank you, Chair. So this sets out your work programme as a committee for the rest of the municipal year. You have one more meeting left, which is on the 2nd of May. And the thinking now is that there is one report scheduled, which is on the suicide prevention strategy, which is being run by Public Health. There have been an intention to take the mental health strategy at that meeting as well, but the department have indicated that they would like to bring that to committee at a later stage at the June meeting. So that means there is some capacity in your work programme, and you don't have to make a decision tonight, but you may want to consider what other items you would like to have at that May meeting. Thank you.
One I was going to suggest was an update on Gordon Hospital. An update on Gordon Hospital. So, but I'm open to any suggestion on the facility to decide on now. Anyone has any thoughts?
Joe, I don't know whether you're interested in us bringing back the home care recommissioning.
Yeah.
That's obviously moved on from the paper that came, I think, in
And would that be ready by May?
That would be just before we're due to go out to tender for it, so we have.
Yeah, I think that'd be a good thing for you.
Yes.
Kevin, agree on that? And any thoughts on an update on Gordon Hospital? Yeah.
No, no.
Let's do down there.
Yeah, that's fine. So we'll go to CNWL and ask them for give them an indication, like an update on the hospital, what's happening around the consultation around
Yeah.
sites, and the liaison department around the home care recommissioning as well. So we can so.
That would be great.
There is one other thing, which is the health and wellbeing strategy that we've been working on. I don't know whether you can just bring that, because I think that'll be in June, isn't it?
Yeah, we're due to consult during April for 8 weeks with the launch in June. So the May meeting will probably be quite timely.
Okay. Do you think in terms of those 4 agenda items that would
Yeah,